Well, thanks. It's testimony to our speaker that you have chosen to be here rather than outside on this lovely Friday afternoon. For those of you who have not met David Batty, he is our first intercontinental professor of epidemiology. He took his training in Bristol and Edinburgh, and currently has two appointments, one here in epidemiology program and at University College of London. He's done a ton of work. If you want to know the number of citations, that's why the internet was invented, but it's lots. He focuses on the big diseases of adulthood and has substantial experience in longitudinal work with a focus in sort of a life course approach to looking at disease and disease outcomes. Today he's going to talk to us about using data from our existing studies and the relative merits of that approach. So without further ado, David.
Thanks, folks, and thanks for coming. So I'm going to describe some of the work we've been doing using existing studies that you have, for the most part, ready access to as well. And I'm going to orientate it around some of the research themes of the college, selected research themes that areas that I've worked in. So it's no means exhaustive, but hopefully it will engage you a little bit more than me just reading through a list of studies that are available publicly and privately. And I'm going to focus also, this is me getting my caveats in, on studies that I've worked on myself. And most of these, I've stratified them according to whether they're publicly available or investigator held is the term I've used. So whether they're publicly available and free of financial costs, and also, quite importantly, free of obligatory collaborators. I went to a baking seminar earlier today, and a colleague was using the Women's Health Initiative data, and you have to involve anyone who wants to be involved from the original investigator team. And as you can imagine, that's quite a long list, and they don't always participate, and it doesn't always aid the final product. It can do, but it can sometimes slow progress and slowly diminish the quality of the final product in some cases. And there's also investigator-led studies where that have maybe some financial cost, and highest there is UK Biobank. This is legitimate cost of building a data set, and UK Biobank, that runs to about $3,000 just now. But down into the other studies, that's a few $100s, and it's often well worth the price. So I'll introduce these studies as I go. I'll present research findings. I'll talk a little bit about the methodology, but I'm hoping to keep this engaging rather than some dry presentation. There are studies also more locally here. Just a relatively rapid search this week. You do have not only search engines specifically for research studies, but you also have individual studies available from individual sites. I was most aware of NHANES prior to this presentation and Midas, but there are a bunch of others too in the States. I don't think it's orchestrated as well as some other countries in terms of a single repository for these data. Okay, so many of you will be aware that this week the World Health Organization released guidelines for physical activity for kids under 5 years of age, including 0 screen time for infants, apparently. And on that theme, I'll talk a little bit about children's physical activity. So these are 3 studies that we're lucky to have in the UK, birth cohort studies, which are curated at the Centre for Longitudinal Studies in the UK. And they've been conducted over a period of time from the 50s onwards. All these data are freely available from the UK Data Archive. So if you were so inclined after this meeting, you could literally go back to your desk, you could register, and you could download these data and have them this afternoon free of charge. This is the UK Data Archive. It's run out of the University of Essex. You have a similar example at the University of Minnesota, I think, for selected social science type data. But the Millennium Cohort Study was conducted in the early part of this millennium. It's about 19,000 kids at study induction. And there's been a move to, in these kids, assess physical activity. So Many of you will be familiar with the self-report devices for physical activity, which, like all self-report devices, have their downsides. People are more likely to report higher levels of physical activity perhaps than they genuinely participate in. It's also very difficult to assess what's thought to be important for health these days, which is the ubiquitous types of physical activity, walking, and also the sedentary types of activity such as sleeping and sitting on one's desk for extended periods. And this is where objective measurement devices have really come into their own. And I remember working as a doctoral student 20 years ago on physical activity measurement devices, and I don't know if you remember those Sony Walkmans, but there was a Cal track around at the time, and believe me, you knew you were wearing it. And the technology's moved on in intervening periods, and they're now these devices that are measured, that can be worn at the waist, at the wrist, and also colleagues recently collected data in several thousand people, and this is a thigh-worn accelerometer, and it's actually, you have a kind of dressing type strapping around it, but you can swim and you can shower, and it's had really good compliance rates. And it's using those thigh-worn accelerometry devices that there's now a collaborative effort available to download. Data are available to download, I think, at a cost, and this is the ProPass consortium run out of Australia, specifically for thigh-worn accelerometry. Apparently they're quite difficult to harmonise across the different body types, different body position. But back to the Millennium Cohort Study, and there are data on accelerometry and distress collected at 7 years of age and 14 years of age in that cohort. And we were interested in this particular study because we were interested in the health impact of physical activity, particularly for mental health outcomes. So in kids, there's reasonably good cross-sectional evidence that shows that kids who are more active are less likely to report symptoms of depression, but those are in cross-sectional studies where there's problems of reverse causality, such that kids who are more likely to be depressed are less likely to be active. So what we really need is longitudinal data, and if you can get it, longitudinal data with repeat measurements. So if you have repeat measurements of an exposure, you can in some way simulate a trial. So individuals in that group who have decided to increase their physical activity for whatever reasons does in some way simulate the active arm of a physical activity trial on a larger study sample with greater statistical power than you would get in a trial alone. And this allowed us to categorise individuals baseline and follow-up at 7 and 14 years of age we did some analysis of the continuous data, but we also dichotomised them at baseline into whether they were low or high, and during follow-up also, so that provided 4 groups, whether they were low throughout the duration of follow-up for physical activity, whether they were high throughout, whether they increased from low to high, and whether they were decreased activity from high to low. What we see is that there's a reduced risk of depression in those individuals who increase their physical activity during that period. And you get an even nicer result if you actually classify individuals according to whether or not they meet the childhood guidelines of physical activity. So it's a nice little tale, particularly if you focus specifically on the lower half of that slide. The reality, of course, is much more complicated than that. Because these data that are existing, it's not a study we participated in, the investigators changed physical activity measurements during the period of follow-up. This is despite a colleague being called to a meeting and imploring them to keep the same core devices. They changed not only the activity measurement device, but its position on the body, and the depression scales were different at baseline and follow-up, and it'll probably explain why this is bouncing around a number of journals at the moment, because there are very real reasons to be concerned about the comparability of those data. Just broadening now from physical activity to other health behaviours, we've used the Health and Lifestyle Survey in the UK, which conducted a couple of periods in the mid-1980s and early 1990s in the same individuals. And there are reasonably good assessments of the major 4 health behaviours. I know some of you are interested in smoking, physical activity as described, boozing, and dietary intake. And that allows us to look at the clustering of those health behaviours over time, because it's true to say that behaviours do cluster. An individual who's physically active is less likely to smoke, they're less likely to drink heavily, and so to look at those behaviours in the round probably gives you a fuller insight into their health consequences. And we're able to classify people at baseline to whether or not they fell into one of the high-risk behaviour groups, so whether they smoked, whether they had high alcohol consumption, poor diet and low physical activity, and that's the category 4 there. And then if they fell into 3 categories, 2 categories and 1, right through to those who were very clean living and had none of the poor health behaviours. And what you see is, presumably what you'd expect really, that the highest risk group, those who had the greatest number of unhealthy behaviours, over a period of follow-up of about 20 years, had the most unfavourable level of survival relative to individuals in the lowest risk group, and then the intervening groups had intervening health risks. An advantage of this study is because there's repeat measurements, we can also look at behaviour change in a way it's quite difficult to in trials. There's some recent trials, particularly the Predimed trial in the context of diet, but we're able to simulate dietary change, physical activity change, smoking change, and drinking change over time, and look at individuals who adopted healthier lifestyles versus those that adopted less healthy lifestyles, and we saw an elevated risk there in individuals who take on a more healthy lifestyle during the period of follow-up in relation to subsequent mortality. I just want to focus very briefly on back in high resolution on smoking. So this is a classic slide. You've all seen this in different contexts. It's looking at socioeconomic status in relation to cigarette smoking. We have, because it's Britain, we have to do things slightly differently. We've got a marker of occupational social class, which is an indicator of prestige. And just to confuse you even more, the higher prestige, the higher prestige is a lower score. So left to right, more deprived at this end, and what you see is what you get in many of the different data sets. Higher prevalence of smoking with greater levels of deprivation, and that's not new. But what a colleague at UCL found was, and just try to bear with me, if you take a group of individuals who have the same self-reported smoking, and you have a biomedical marker of smoking intake in that group, whether it's passive or direct, something like cotinine, which is an anagram of nicotine. If you have a biomedical marker in those groups of people who apparently self-reported the same level of smoking, you still get the gradient. So you still see that poorer people have a greater exposure to primary and secondary smoking, even if you keep constant self-reported smoking. And that might be, at least for 2 reasons. One might be that there's underreporting of smoking in poorer social groups, less educated social groups. It could be that they're smoking differently. So my sister's first memory, and epidemiologists are really good at this, they're using anecdotal findings to support their own research, but then hammering other people for doing so. My sister's first memory of my dad is coming home from preschool and watching him clean the car, and he had a capstan full-strength cigarette pushed in the corner of his mouth, and he lit it, and he only took it out of his mouth when it had burned down all the way to the nub. So there's a suggestion that people in poorer social groups smoke cigarettes differently. They're in the mouth for longer, they inhale more deeply, they maybe choose higher tar cigarettes, they maybe choose longer cigarettes. So the dose of cigarette smoking may be actually higher given the same self-reported intake. Now, if you follow that argument through, so is there a greater level of toxicity for the same apparent health behaviour in people from lower social groups, as reflected in, say, mortality experience? So in other words, if you take, if you have an affluent group and a poorer group, in the poorer group, for the same level of health behaviour, do you get higher relative risks for a given health outcome, given this apparent finding of a higher level of apparent toxicity in poorer folk relative to more affluent? And we were able to look at this, and if you came to my job talk last April, where I presented distress data, psychological distress data from these studies, we've repurposed them to look at this particular question. These are studies conducted routinely in the UK to measure the health of the population. And we're collecting data in these studies that we can't collect routinely, so information like cotinine and self-reported smoking and angina. And we've been able to look at these studies collectively in an individual participant meta-analysis. And what we actually find is that there's no difference across the socioeconomic groups. So by education, high education, mid-education, low, and if you look at the gradient for smoking in relation to total mortality, there isn't actually effect modification by social group. This is actually discordant with more recent results from Biobank, which I'm going to describe shortly, UK Biobank, where they've looked at health behaviours collectively and have in fact found steeper effects, so some evidence of greater toxicity of adverse health behaviours in poorer social groups relative to the more affluent. And the p-value for interaction is there, fits the conventional standard. Okay, so I mentioned UK Biobank, and we've been interested in looking at some of the health consequences of health behaviours, particularly diet and physical activity as expressed, of course, by energy intake, energy outtake, particularly obesity within this cohort. We're interested in the relationship of obesity to outcomes that are, health outcomes that are less conventionally being looked at. So UK Biobank is one of these initiatives that is set up to look at gene-environment interaction. It's predicated on very high numbers. It's also predicated by design on a trivially low response rate. Or it's not the number is trivially small, the consequences are considerable. But in order to get to 500,000 people, I'm going to talk more about this at the Ignite event, they had to knock on the doors figuratively of 10 million people. And this was built in as a cost-saving measure. So if someone didn't respond, and most people don't respond to a request to participate in a survey, they didn't follow them up. They went and knocked on another door, they sent a message to another individual. So the response rate is trivially low. They will argue that that has no implications for etiology. It has implications for estimating prevalence, but no implications for etiology. And there are a number of other studies along these lines that now, admittedly with higher response rates, but there's the Biobank from Norway, there's the Chinese Biobank, and there's now the US All of Us study. Really? The All of Us study? I mean, you imagine a marketing firm in downtown Manhattan being paid hundreds of thousands of dollars to come up with All of Us. Okay, so this is 1 million people. It's ongoing data collection. I'm not sure if the data are available in the intervening period, but it follows Barack Obama's State of the Union address, I think in 2010, where he had a focus on precision medicine, and he released at least $200 million for work in precision medicine, and this was partly the result. There was many other endeavours undergoing. We've used UK Biobank. These are data from individual participant meta-analysis, but we've used UK Biobank to investigate this question, the notion that obesity is related to an increased risk of the outcome of a moment, which is dementia. And so you do see somewhat higher risk of dementia in people who are obese, and that's probably not surprising given that dementia is thought to have a cardiovascular disease origin. There's actually some very large studies showing the reverse, that obesity is associated with protection against dementia in the way that it's also associated, and people don't talk about it, with protection against lung cancer. In both cases, it's probably reverse causality, but in the better controlled studies, there seems to be an association between obesity and increased risk of dementia. And we were thinking, okay, well what's the mechanism going on there? And in UK Biobank, remember this is 500,000 people, but they have these sub-studies, and the sub-studies, when you've got 500,000 people, are very large in their own right, and they've got the aspiration is to brain scan 100,000 individuals over the course of several years. We're currently at the stage where I'm not involved. We're currently at the stage of 10,000 individuals brain scanned. And this is 2 orders of magnitude at least greater than existing studies on obesity and brain imaging. If you go to the literature, a lot of the studies are 10 or 20 people. Sometimes the number of authors is higher than the number of study members. Sometimes the authors are the study members. But this, creates great opportunities for individuals like me and others to use these data. And these were results that were very much led by Mark Hamer. And he found that higher levels of BMI, irrespective of the age group, and in this particular sub-cohort also there was lower levels of grey matter volume and white matter volume in individuals with high levels of BMI, and we know that lower volumes of grey matter are linked to cognitive decline, low levels of cognitive function, dementia in itself. So obesity, like lots of the characteristics we're interested in fact, almost all the characteristics we're interested in that have some control over health, do time vary. I talked a little bit about in the context of physical activity, but you see this for just about every outcome you could be interested in, such as inflammation, blood pressure, and so on. And even these days, there's over time there's changes in ethnicity and of course gender is very much in the news. And depression is no different to this. I've got sorry, this is just to illustrate. I should say that I had this set up in my office, and I had the slide that I'm showing and the slide I'm about to show, and I could have seamless links between the two, and now I've just got the one I'm showing, so I'd sometimes miss the actual transition. But these are data taken from the Whitehall I study, where we have a survey and resurvey 30 years apart, and it shows how little relationship is, how poorly certain characteristics track. So for blood pressure, there's very low inter-survey correlations here. For blood glucose too, somewhat higher for height, although there's some osteoporotic vertebral collapse. Low correlations for cigarette smoking. So that's just to say that these behaviours vary greatly over time. So the more times you can capture them, the better. And certainly depression is no different to any of these. I've been interested for a while in the relationship between mind and body, in particular cognition and physical health, and also mental health and physical health. And these are data taken from the US, where there's in an older cohort of folk, there's 5 measurements of depression. And using linear growth curve modelling, you find that there's various groups of depression trajectories emerge over time. In particular, there's a rise here in folk reporting depression symptoms. This is an elderly group, so that might be due to physical ailments and the impact on mental health. But there is change over time in this variable. And so if you're interested in the impact, as I am, of mental health and physical health, you need to capture it as much of the life course as possible. And ELSA allows us to do that. This is the English Longitudinal Study of Aging. We've now got 8 or so waves of data collection, and this puts it into the same category as the esteemed Framingham study, which has every 2 years data collection on the participants and also the offspring of participants. And it's actually a really small collection of studies that have this resolution of data that's managed to maintain funding over a long period of time, and this has had core funding. ELSA's had core funding from NIH for many years, for reasons I'll explain in a minute. And so we're able to look at the trajectory of depression in the first 4 waves, and then after that, because we've got relatively straightforward mortality surveillance in a small country like the UK, we can look at mortality patterns in relation to those trajectories of depression. And what we find is that, so we classified it as a case based on symptomology in individual at each point of follow-up, whether a case or whether they weren't. And those that were a case throughout the period of follow-up had the highest mortality risk relative to those who had 3 points of follow-up or a case, 2 points of follow-up, and so on. And the lowest mortality rates were seen in individuals who didn't report any significant depression symptoms during the period of follow-up. And you can express that in a survival model, and you find about a doubling of risk in individuals who have the greater level of chronicity for depression. And that doesn't seem to be diminished that much by controlling for socioeconomic status and health behaviours and illness and whatnot. Now, the ELSA is part of what's quite rightly called, I used to be a little bit more cynical about this, but it's quite rightly called the HRS family of studies. The HRS, US HRS being Health and Retirement Study, and it's family of studies because the NIH have in some way paid for very significant data collection in all of these studies for some or all of the data collection. And there's about 12 studies nationally now, internationally now, and they used to be named after people. So there was the Chinese study here, was called Charles, and then there was the ELSA study, of course, and then there's the Tilda study, and then there's the Nicholas study, and now it's moved on to food groups. So the Scottish study is called Haggis, the India study, anyone? It's called Lassie. The Malaysian study is called Mars. I don't know if that's intentional or not. The Mexican study is actually called the Mexican Health and Aging Study, not TACO, as one would anticipate. But quite brilliantly, the colleague Jin Kook has combined all these data into a single search engine now. So if you're interested in aging studies, and I know some of you are, you can go to the Gateway to Global Aging Data website, where you'll see two old people looking very wistfully over a major suicide hotspot. And you can, as long as you can get past that mentally, you can then start looking at the individual data. You can ascertain if your variable du jour is available in that data set. You can actually run some descriptive statistics on those data. It's a really good website, and I'd heartily recommend it if you're into aging research. Okay, so keeping the aging theme going, we for some years the British Medical Journal in the UK has taken more tongue-in-cheek papers for the Christmas issue, and we were interested in the tongue-in-cheek element, but we were also interested that there's a serious side to it, and there was a statistic that emerged relatively recent in the UK, and this feeds very much into the loneliness agenda in older folk. And that there was high levels of loneliness reported, and actually rather tragically 12% of some communities over the age of 65 years of age reported that 10 to 12% reported that their major form of social contact was via their animal companion. And it's obviously sad for many reasons, but the fact that about 50% own pets mean that it's, from a public health point of view, it could potentially have impact. You could potentially take animal companion dogs to aging centres, just as often taken to kids' hospitals. There's a general belief that animal companionship and pet ownership is positive. There's probably reasons to anticipate positive and negative impacts on health. So there are counts, and the literature is quite thin, and it's across multiple fields, and it's difficult to get a grasp on. The quality of the science isn't always great. But there are accounts of individuals who own pets delaying their own health treatment in preference to that of the ill pet, which obviously is detrimental for their health. There's obviously only distress after the death of the pet, which I completely understand. There's also evidence of positive impacts on health. So we're told, and again the data are thin, that if you have a pet that requires a lot of care, like walking a dog, that might benefit your physical activity level and might have knock-on effects for weight regulation, also cardiometabolic benefits. And this isn't just whimsical and comic. There's an AHA statement, American Heart Association statement on pet ownership and cardiovascular disease risk, where it says that there's probably an association, but like every statement, it ends more research is needed, and methodologically it's a little bit thin here and there. And we didn't think we could contribute much to that area, but we thought about, given that it's an aging population, what's the link between pet ownership and aging markers? Because some of the very common markers of aging, and there's a statement now on what you should measure in aging studies are physical measurements like balance, how fast you can walk, how good is your grip strength, all of which could be related, and also mental health, all of which could be relating to pets. I should declare a conflict of interest here. I do love animals, particularly organic reared ones, roasted with a collection of vegetables. So we all have our priors. And what we found here is we have self-reported pet ownership. This is an ELSA. So whether someone reported not having any kind of pet, a dog or a cat. Because this was Christmas BMJ, they inserted these kind of emoticon type things. We didn't do that. And we related pet ownership to a number of different outcomes. Physical functioning measures here, which there were 4: chair rising, grip strength, gait speed, how hard you can blow into a tube, force expiratory volume in 1 second. And just to give you a very brief overview, we found nothing for physical functioning, for immune functioning, including C-reactive protein, which is often measured in a clinical setting these days. And even for the much vaunted impact on mental health, there were no associations with depression symptoms, and there were no associations with memory. So a rather null result. So I was invited, because I'd worked in Scotland for a while, I'd done some research in Scotland to go there and give a presentation on mortality experience of people from Scotland, which historically, as many as you'll know, we have much higher rates of mortality in Scotland than we do in England and Wales. So I wanted to call it something like Dying Young in Scotland or something like this, and the organiser said, no, you have to be optimistic and positive. You have to call it Living Longer in Scotland. I said, oh, okay. And so I did, and I presented this slide, which shows differential in mortality between populations in Scotland. These are using census data, and we have a census every 10 years on the first year of each decade. So in 1981, there was a differential in mortality of around 5%, which rose 10 years later to 8%. It plateaued, but then the differential has increased. And there's lots of explanations for this differential, and you see it in many countries of the world between selective cities and between the countries here as well. Even within Scotland, there's great mortality differentials between Glasgow and Edinburgh, the West Coast and the East Coast. And there's a number of reasons offered for this, none of which have been terribly well empirically examined. But the most obvious one is socioeconomic position. So there was grinding poverty in for essentially when the demise of shipbuilding occurred, particularly in the west of Scotland. And socioeconomic differences between the countries is certainly one explanatory factor, but there are a number of others. And we were able to look at this using existing data from 3 cohort studies, which are representative of the cities, but not representative of the countries. And I'll come back to that in a moment. But we had 2 studies from where I used to work in Glasgow, and one where I couldn't really work, and dividing my time, of course, between here and London. And so these are cohort studies of cities which we took to be representative of the countries, and we related the mortality pattern in the cohorts in Scotland to the mortality patterns of the single cohort in England, and we found higher rates of mortality in the Scottish studies relative to the English studies. And this, for total mortality, was almost completely explained by the higher prevalence of known risk factors, smoking, particularly poverty. It didn't explain it for other specific outcomes like stroke and accidents and suicide. And of course, being very specific to those cities, the generalizability is debatable, and there are a rather low number of studies for these kind of environmental analyses. So we tried to improve this using the studies I've already described to you, the Scottish Health Survey and the English Health Survey, which are much higher numbers. We know them to be representative of the countries from which they're drawn, and so it's a stronger set of analyses really. And I already told you about the studies. And we saw, again, if you lived in Scotland, you had a higher mortality rate than individuals living in England, about 40% increased risk in the most basic model. And if you add various explanatory factors like smoking and alcohol consumption, existing illness, it had a modest impact. It felt the hazard ratio fell by about 25%. And colleagues in Scotland who are really committed to the concerns of mortality and health in their population, and particularly in Glasgow. I've written extensively in this, and I've really tried to hang on to their apron strings, and they've come up with a number of different hypotheses for why these differences may exist beyond the ones I've just described to you. And out-migration is a possibility. People that migrate are typically healthier than those that ones that stay behind. So if there's mass out-migration from Scotland, then that would increase the mortality rate of the people left behind. There's been severe periods of deindustrialisation across Scotland, which was largely attributable to Margaret Thatcher's regime. And there's, of course, great differences in climate between England and Wales, which is starkly reflected in vitamin D levels between the two countries. And these are hypotheses as yet not very fully tested. Okay, so I'm coming to the end now. So I want to bookend the presentation. I started out with the Millennium Birth Cohort Study, and I want to bookend it with the 1958 Birth Cohort Study, so named because, of course, children were born in that year, and they were born on a specific week in that year. And this is how data protection has gone bonkers. I'm not allowed to tell you what week they were born in 1958. If you go to the early publications, the dates of their birth, just the days in that year are given, but through non-disclosure, I'm not allowed to tell you which dates now. Anyway, so best laid plans, we wanted to go into the field and had a biomedical survey in these folk when they were 60, which is of course 2018. It's now 2019, and we haven't done that. We weren't successful at getting money at the first round, but we've got some money now to go into the field in 2020. This study is characterised by data collection across the life course, mostly in the field of social surveys, not a lot of biomedical data. There's biomedical data collection here. There's bits around the perinatal survey, but mostly it's social surveys, social survey orientated. But it does provide a really fertile collection of data to look at the early life origins of adult disease, of course, because you've got these repeat measurements across the life course. And what has a lot of interest, I think, to this group and other groups is the impact of adverse childhood experiences on later life health. And there's probably no better depiction of early life adverse child experiences than being looked after, so going into care. So this is really a euphemism for foster care. And we're finding in the UK, and you have similar gradients in the US, increasing number of kids being taken out of what is regarded as a very vulnerable situation, placed into care. And the idea is that the care provides a much more protective environment than the one they're currently in. However, that doesn't always seem to be the case. There's good evidence now that kids, relative to those that weren't in care, or the general population, depending on which study you look at, those kids subsequently have emotional and psychological problems. Socioeconomically, they don't fare as well. There's greater rates of chronic disease. And for these reasons, we wanted to look at the impact of going into care on subsequent life expectancy in these kids. We're able to do that in the 1958 birth cohort study using individual participant data, and also in the 1970 birth cohort data. But we also put this in the context of a review of existing studies, of which there actually aren't that many. And we found that kids who were in care had about twice the risk of premature mortality. This is mortality up to 51 years of age, than kids who hadn't been in care. And it's pretty consistent across the studies. These are the individual participant meta-analysis, which I call unpublished data. And these are studies, existing studies, some of which have general population-based samples, which is why the numbers are missing in certain cells. But it's fairly consistent. There's high heterogeneity, but every study is to the right-hand side, showing an increased risk in kids who are in care. So then the next question, because these aren't all terribly well characterised studies, the next question becomes, well, how is out-of-home care embodied to increase risk? And I've talked about psychological problems and socioeconomic deprivation in kids in care, but we were wondering if there's any kind of biological embedding in kids who have been in care, if there's some physiological changes when we follow them up. And we follow them up at age at age 44 for a number of biomarkers. And we found that there was very little association between being in care on inflammation, classic cardiovascular disease risk factors. It's probably quite a good teaching point in this. If you take your classic p-value, p less than 0.05, and you conduct 20 tests, one of those is going to surface by chance alone. And we did find effects for clotting agents, but I don't really believe it. I did skim past a slide here, because this is back to the mortality. We were interested in whether timing of going into care had an impact on mortality. So you can imagine an infant or a very young child, lower levels of senescence, not aware as much of what's going around them, that the impact on them at that age may be diminished relative to a kid who's gone into care in their adolescence. And we did find that children who went into care later in life had higher mortality risks than those that went into care younger in life. Okay, just to end on a whimsical point, for the educationalists among you, amongst a battery of tests that were conducted along the lines of cognitive function, there's also tests of coordination, the 1958 cohort study. So that would stem from how well you can walk backwards along a line, standing on one foot, bouncing a ball, picking matches from a pile and placing them into a box. So from gross to very minor motor skills, and how well you did on those tests does, to a degree, govern how well you do it educationally. So kids who do well on the coordination test, typically they handwrite competently earlier. There's also some evidence, I don't fully understand it, I was trying to understand the paper yesterday, but there's evidence that kids who do well on coordination tests have lower levels of BMI in later life, and that might be because they're more likely to participate in sports because it's easier and more fun for them, I suppose. But this paper got into neural pathways, at which point I switched off. But I'm sure it meant a lot to the author. And so we've looked at the coordination in relation to mortality experience in this group, and we find effects across all the different tests of coordination, from standing balance, which are the agent type test, to match picking, to number of ball catches. But what actually comes out most strongly is whether or not with the teachers and the mother's own qualitative view of how well the kid did, how well coordinated the child was. Okay, I'm going to finish now. Just to conclude, certainly using existing data has some advantages, including allowing you to look at research questions in a very rapid fashion. There's inevitably some downsides. Often when you're dealing with requests, making requests to curators, it often doesn't get turned around as quickly as you want, so you can be left twiddling your thumbs for a while. Increasingly, however, and we've got social scientists to thank for this, not epidemiologists, certainly not epidemiologists, and certainly not medical scientists. The availability of data has increased exponentially in recent years, and that's through people like economists and psychologists freely sharing their data, and we're just hanging onto their apron strings and trying to do the same, as we should. There is a perception in the field that it's somehow less scientifically noble to use existing data than collect your own and use your own data. And I've been involved in data collection and designing data collections, and I think that they both have their merits. But if you want to, I can think of several important public health examples that have used existing data sets. Most recently, and most obviously to me, is the association of no effect between measles, mumps, rubella vaccine and autism. That was based on a routinely collected data set which was freely available, and a colleague in London used it, and many others have used it subsequently. I've shown that there's problems with core measurements over time because you don't have input into them, and there's also a problem with duplication. These are just, I don't think it happens a lot, but these are examples of the same questions that have been analysed by different groups using the same data set and have led to dual publications, which, I'll be honest, if you're supervising a Ph.D. student and that happens, it hasn't happened to me, but that's really difficult for them to take. and if you're a junior researcher, it's very difficult to take. I speak to economists about this, and they will say this is the way it should be. You should have different groups looking at the same questions in different ways and testing conclusions. I think that I don't think epidemiologists regard it that way, but anyway. So there are some examples, and I've talked as if I've done all this work. There's a bunch of better looking, more intelligent, harder working people who've done the heavy lifting. And if you were at my job talk, you'd have seen me depict Stephen Bell by a pug. He still has no representation on any media sites, and he's really happy to be represented by a dog. Thank you.
So we have a few minutes left for questions and discussion. Have at it.
I just have a general question. Since you are from UK, so I just want to know whether the political issues are affecting the academic research recent years, such as the UK tried to break free from the EU. And what's your
We tried to break free from EU. Bloody hell. I've been in Oregon 4 weeks and what happened?
Yes, so, sorry, that was clear. So the biggest concern amongst researchers is that we can't apply for European money. So the EU money is vast. There is an organisation called the European Research Council, and so it's the funding, studies that are currently funded by the European Research Council, the ERC, can go ahead, and for whatever point in the present time that you get funding, you can conduct your work, but subsequently, it's probably a big pot of funding that we're not going to be eligible to apply for. So you've got people like me, we've got some distant Irish relative thinking, oh no, I'll get a new passport, and that'll make me eligible. But that's the most obvious impact. I mean, from a scientific and academic point of view, it's incredibly depressing for me, because it means that the big brains aren't going to come to the UK. It means that there are certain sections of the UK that have been emboldened in their right-wing philosophies. And I think outwardly there's the view now of the UK of being an unfriendly little island, and it's not. And I'm ranting now, and that doesn't answer your question.
A clarifying question.
Yeah.
You know the out of home care?
Yeah.
Can you clarify, are you talking about foster care? Are you
Yes.
talking about kids removed from the home?
Kids removed from the
Not
home.
in preschool.
Sorry?
In America, when you say out of home care,
Yeah.
it often can mean like preschool.
Yeah, I think that's why I said it was a euphemism. It's kids who are between 0 and 18 who are taken out of their home, largely because the home is a unstable, dangerous environment, or they have behavioural problems themselves. They're usually placed in foster care. It could be, in the 50s, it could have been on occasion what we used to call children's homes, which are less common now.
And then I have another
Please,
question.
yeah.
The coordination stuff, so there's a lot
Yeah.
of research on the effects of, so I couldn't quite tell, but so visual motor integration, so like fine motor,
Yeah.
with young kids being really related to cognitive outcomes.
Yes.
Versus the gross motor. So
Yeah.
I'm wondering if you were able to
Yeah.
separate out fine versus
Yeah.
gross.
So that's a very good point. So there were a bunch of coordination tests that were cognition-like. I mean, there's all element of cognition in all of this, and we excluded those. And then because there is something like a square marking task as an element of reaction time and information processing about it, which is related to cognition. So for those kind of tasks, we control for cognition testing, which is very, very good in this particular cohort, and the effects held typically. They were diminished, but they held.
We had also looked in the randomization study that one of the best predictors of mortality was actually manual dexterity
Right.
test, and I was sort of turning my hair trying to figure out why. And as best I could tell, the manual dexterity test and handwriting is actually the best predictors because it looks across brain coordination.
Right.
And it's also very sensitive to existing illnesses.
Right. Yeah, I would think it would be quite a good marker of comorbidities. Yeah. Yeah, and there's also evidence that individuals who have an acceleromotor of sorts, and haven't been involved in the work, who become less stable over time, as measured by electrometry, they have an increased risk of subsequent Parkinson's disease. They might be picking up the early stages, which is related, I think.
Well, thank you very much, and I'm sure Dave will stick around if you have additional questions.